Hello everyone, Assalamu alaikum. I am Fiza Gilani, Chair of the APPNA-MERIT HIV Committee. Welcome to the 7th webinar of HIV Awareness, Prevention and Education Project in Pakistan, jointly designed by APPNA-MERIT HIV Committee in partnership with the Common Management Unit, HIV, TB and Malaria, Government of Pakistan, and the Medical Microbiology and Infectious Diseases Society of Pakistan. This is the first webinar of our monthly webinar series and 7th in the overall HIV webinar series. Today's moderator is Dr. Fiza Rafiq. She is a medical graduate from Fatima Jinnah Medical University, Lahore, Pakistan, currently working in Calgary, Canada as a family physician at Trans Canada Medical Center. She is a clinical faculty at University of Calgary, involved in teaching medical students and residents. She's a lifetime member of APPNA, MD International, and current president of the Fatima Jinnah Medical University Alumni Association. So Dr. Fiza Rafiq, here you go.
Thank you so much, Dr. Fiza Gilani, and Assalamu alaikum, everyone, and good morning and good evening in Pakistan. So today's topic is a very interesting topic. It's a lifelong care of infants and children living with HIV. And we have three great speakers today. And it's a very special webinar where we have three pediatric HIV physicians from USA and one from Pakistan. And I'm very happy and pleased to announce their names and little bit short bios of them. All three physicians from USA are affiliated with the Alpert Medical School of Brown University, Rhode Island, USA. So first speaker will be Dr. Jerome Larkin. He's the Director of Inpatient Infectious Diseases Consultation Services. He specializes in internal medicine and infectious diseases, and he sees pediatric HIV patients at the Hasbro Children's Hospital. So welcome, Dr. Larkin, and I think you can start with talking about pediatric HIV disease and its history. So that will be the topic of discussion by Dr. Jerome Larkin.
Sabina, you have your slides?
I do. I don't know that Dr. Larkin has logged on.
Okay.
Actually, he is on a place in Block Island here in Rhode Island, and that's a completely separate island. Hopefully he will be able to join. But Sabina,
so
you want to start?
Dr. Sabina Holland, can she start then? Our topic?
Oh yes, I'll start from the beginning. That will work. Can you see the slides?
Yes.
Yes. Okay.
Perfect. So I will introduce Dr. Sabina Holland. She's an infectious disease specialist and assistant dean of medicine for the PLME for diversity and is responsible for developing innovative ways to increase diversity in the medical residency program. She is currently the medical director of the Pediatric HIV Clinic and specializes in improving the transition from pediatric to adult care for adolescents living with HIV. So Dr. Sabina Holland.
Thank you. Thank you for having me. So we'll talk a little bit, we'll start by talking about the pediatric HIV and the presentation, and then we'll move into treatment. So this is AIDS info, and that's where we use our guidelines here in the US. Additionally, you can also go to this website, as well as, the WHO just recently put out a new version of the consolidated guidelines. So moving right into, what you can see in terms of symptoms. And this is both for children and as well as adults. Acute HIV, which occurs in the first 2 to 6 weeks after infection, can resemble an influenza or mono-like syndrome. And clinically, what the patients will experience is fever, rash, sore throat, muscle ache, headache, vomiting, diarrhea. They can have a stiff neck. They can have lymphadenopathy, and so it really looks like infectious mononucleosis. It's associated with very high viral load. You also see a decrease in your CD4 count. At this at this point in the illness, there's a really high risk of secondary transmission. Typically what happens though is the patients get better, the symptoms resolve, and you start to see a detectable antibody. In this period of time, especially in the first 2 weeks, depending on which platform or which diagnostic test you have available to you, you need to use a viral load to diagnose the infection, especially if your antibody test is in like one of the first or second generation tests. In terms of thinking of infections in children, most children are infected via maternal to child transmission, and that's something that we did see before. Now in Rhode Island, because of mother to child transmission, I think Dr. Larkin was able to get in.
I'm here.
Oh, perfect. I will turn it over to Dr. Larkin.
Okay, sorry. Some technical difficulties, which I was surprisingly, for me, actually able to surmount. As Dr. Holland was saying, most infections in children are from maternal to child transmission. Most are potentially preventable. And of course, it's all compounded by geography, decrease of access to care. The fact that at least worldwide, most women deliver at home and may not be aware of their own diagnosis and not have been tested during their pregnancy. Next slide. I don't know who's running the, Sabina, are you running the slides or is Fiza? Okay, Fiza, let's say. Okay, so overall, pregnancy in utero transmission is about 5 to 10%. And then another 5 to 15% from breastfeeding. And then actually during the time of delivery, 15%. So that actual administration of antiretroviral therapies just at the time of delivery can significantly decrease transmission. But overall, there's up to 40% transmission if no steps are taken to control the infection or prevent mother-to-child transmission. Next slide. So this basically is a schematic of the natural history of HIV, where at the time of diagnosis, in the case of an infant, either in utero or at the time of parturition or during breastfeeding, the CD4 count and the blue curve is initially very high or normal. It drops precipitously at the time of infection, then usually rebounds to a relatively immune competent status, but then declines over the course of 5 to 10 years. And we'll talk a little bit more about kids who are rapid versus slower progressors. And then in the red graph, what you see is the viral load, which of course is 0 at the time of infection, then skyrockets sometimes up to the millions of copies. And then again, also typically will decline to what's called a viral set point that can be in the tens of thousands or maybe even hundreds of thousands, depending on the interaction between the immune system and the child and the virus. And then gradually will increase over time, whereby sort of the race is lost by the immune system and won by the virus. And you see the onset of opportunistic infections and then ultimately death. Next slide. So in that latency period, when the virus and the immune system are sort of in an arm wrestle, you see ongoing CD4 destruction and worsening immune function and viral replication. You'll also see, especially in children, lymphadenopathy and hepatosplenomegaly, and there is a status of hypergammaglobulinemia from B-cell clonal expansion. Next slide. The interesting thing about HIV is that it's very error-prone, and there's billions of virus made every day. It has a relatively small genotype and genome, and so actually every single day, there's probably some mutations, at least a few of every potential mutation in the genome, and the entire viral population is overturned within about 72 to 96 hours. However, there's a latent reservoir infection, primarily in lymphoid tissue, that can that leads to long-lasting infection. Next slide. So the median time from HIV to infection to symptomatic disease in adults is generally speaking about 5 to 10 years. However, in children, particularly those who are infected perinatally, it can be a matter of months or 1 to 2 years. 5 to 10% of adults have stable CD4 counts and no symptoms even after many years. And these are known as elite controllers. They used to be called long-term non-progressors. And then actually 10% of adults progress to AIDS in 2 to 3 years. So they're more rapid progressors. Next slide. The CD4 count is the best predictor of the presence of the risk of an opportunistic infection. Treatment is always indicated if the CD4 count is less than 200. And current US guidelines and WHO guidelines, depending on the situation in a given country, recommend treatment for all people living with HIV, regardless of age, CD4 count, or their viral load. Next slide. The CD4 count can also be matched with a percent, and the percent actually has the best intermeasure consistency. And that's important in children because of the evolution of their immune system in the first 5 years of life. Next slide. So you see in children under the age of 12 months, their CD4 count is usually 1,500. In adults, it usually runs somewhere between 500 and maybe 1,000 or 1,100, depending on the validation of the assay. Between 1 to 5 years, their CD4 count is between 750 and 1,500. And then over 6 years, they have more adult-like numbers, so greater than 750 in most cases. The importance here is that you can be misled at a very young age. If you look at a CD4 count and say a 3-month-old and it's 1,100 and you think, well, that's a pretty good number. It's actually not. It's actually a degree of moderate immunosuppression in a child. What you want to look at is the percent, and that should always be greater than 25% to denote normal immune function. Next slide. So we think of moderate immunodepression as between 15 and 24% in that second line, and then severe immunodeficiency when the CD4% is less than 15%. And that can correlate with less than 750 in a less than 12-month-old, less than 500 in the 1 to 5-year-olds, and then less than 200, again, more like an adult number in greater than 6 years old. And this is really one of the principal differences between children and adults. To make two really broad generalizations, and of course, generalizations always fall apart in the particular, or can fall apart in the particular, but one of the interesting things is that the differences between children and adults are not that substantial. For instance, in general, they respond to antiretroviral therapy the same as adults. However, one of the big distinctions is their immune status based on their CD4 count. And then the other is that there's a few opportunistic infections that children are more prone to. And then lastly, children have a higher risk, especially with perinatal transmission, of more rapid progression. Next slide. So this is just a chart showing more or less the same information. There's a lot of information on the slides. I'm not going to go over specifically. I just want to leave it there for your reference. Next slide. And next slide. So HIV infection in children is roughly divided into two groups. Those who progress more rapidly, and that's between 15 and 20%, significantly higher than in adults, and those who progress more slowly, and that's about 80 to 85%. Mortality before age 4 in that very rapid progressing group is very high, with median survival of about 11 months from time of diagnosis. Viral load increases rapidly in infected infants in the first 2 months of life and then declines over the next 2 years. However, which compared to adults who decline in the first 6 months after infection, children take longer to exert that relative control over the virus, and they are less likely to have a lower viral set point. For this reason, all infants aged 12 months with confirmed infection should receive antiretroviral therapy and PCP prophylaxis beginning at 4 to 6 weeks of age. After 12 months, depending on the national guidelines, you may not decide to treat a completely asymptomatic child who appears to have a relatively normal CD4%. That varies quite a bit between countries, and I believe Dr. Holland will address that later. Next. So there's, as with in adults, basically HIV is a textbook of infectious diseases. They can present with numerous different clinical manifestations or opportunistic infections. But in children in particular, there is a few things that are relatively more common, and these include parotitis, encephalopathy or failure to thrive, and this thing called lymphoid interstitial pneumonitis. But as with adults, they really can't have anything, particularly things that rely on cell-mediated immunity to control. Next slide. So I'm going to go through a few different clinical manifestations really briefly, and then I want to turn it over to Dr. Holland and Dr. Bird, who are far smarter than I am. So this is an example of PCP pneumonia. What you see is sort of what is referred to sometimes as a butterfly infiltrate. So that sort of perihalar, sometimes more reticular nodular infiltrate. It can have very many appearances, but this is sort of the typical radiograph of a child with PCP. Next slide. So it is the most morbid diagnosis to have in a child, and 50% of AIDS diagnoses in the first year of life will show this. And it can be a very occult disease, presents with tachypnea, hypoxia, but a relatively normal pulmonary exam. It may be very insidious. In children, it may present with poor feeding and weight loss rather than actually overt pulmonary symptoms. And Bacteremia is the standard treatment, usually with steroid. The mortality is up to 100% if untreated, 5 to 40% with treatment. Next slide. So this is an example of something called lymphoid interstitial pneumonia, which is almost unheard of in adults and still very rare in children, but a more common diagnosis. Next slide. What you see is a more interstitial infiltrate. Tend to present in children who are older with an insidious onset. It's associated with lymphadenopathy and hepatosplenomegaly. It may be related to EBV infection. It overall has a much better prognosis than PCP and seems to be, for unknown reasons, somewhat protective of PCP developing. Treatment is with steroids if they have exacerbations or an oxygen requirement, but is largely supportive. There's no specific treatment for it other than antiretroviral therapy itself. Next slide. So this is an example of hepatosplenomegaly. You can see you can't really see it too well, but this child has a markedly enlarged liver. Next slide. And this is an example of parotitis. Again, something that is very characteristic of children with HIV. So unexplained swelling of the parotid glands, not usually typically overtly inflamed or painful, but should prompt suspicion of the diagnosis. I have seen 1 or 2 adults with this, relatively uncommon, however, in that age group. Next slide. And this is just an example of a lobar infiltrate. Next slide. Children are also at high risk of typical bacterial infections, particularly strep pneumonia, Haemophilus, Staph aureus, Pseudomonas, and particularly in areas of the world where salmonella infections might be more common, salmonellosis, and that can be a primary bacteremia or other foci of infection, such as the bone or gastrointestinal tract. That's also one of the important reasons why Bacterem prophylaxis is important. Next slide. This is just an example of HIV wasting. The same child on the left in the pink shirt, once on effective treatment, you can see has a more robust appearance on the right. Next slide. So in children, HIV may present rather insidiously with persistent weight loss, crossing of growth curves, or less than 5% in weight for height and chart on 2 consecutive measurements. And so that should also prompt possible evaluation. Next slide. And this is an example of oral candidiasis. Again, one of the more typical presentations of HIV in small children. Next slide. As it is with adults, but it may present as drooling odonophagia or the complaint of retrosternal chest pain, which also should prompt consideration of esophageal involvement. Treatment is with fluconazole. Breakthrough can be used with can be treated with other azoles. Next slide. And then lastly, developmental delay in encephalopathy, which is manifested by failure to retain or loss of milestones, impaired brain growth or atrophy. You may see gait impairments, motor deficits. It is usually static, but may be progressive in the most severe cases. It's typically seen in the first year of life. And it's also oftentimes associated with other manifestations of HIV, such as a high viral load and CD4 count, and it results in increased mortality. Treatment is usually antiretroviral therapy. There is some thought that perhaps efavirenz and AZT may offer a benefit. That's never really been proven, but the reason for that, or the rationale anyway, is that they have good CNS penetration. Next slide. I believe that's it for me. This is just, there is a WHO staging of HIV and AIDS. I would refer to your national guidelines or local practice. Next slide, I think. Okay, these are the slides I cut.
Yeah.
WHO actually has its own classification system, and at least by WHO guidelines, generally speaking, all children should be treated regardless of their HIV status. The only exception is if they are in category N, which is completely asymptomatic. And that is usually only if you have if you do not know what their CD4 count is. If their CD4 count is known and it is less than 25%, then you would want to treat as well. Next slide.
I think the rest are the classification.
Yeah, okay. So we could probably just go, skip that. It's there for your reference. I've sent these slides to Dr. Gilani, and she is completely welcome to share them with all of you. The last thing I would say, one last point. So most of the HIV in the world is type C. So HIV is divided into many different subtypes. B is most common in the United States. And so in that regards is somewhat more studied than type C. C predominates in sub-Saharan Africa and parts of Asia. That can be a problem when doing viral load testing because older PCR assays for RNA did not necessarily detect these other subtypes. So you just want to make sure that if you have access to viral load testing, that it's been validated in the population in which you are seeing patients. And then also there's always the possibility of HIV-2. I don't think that there is any really in South Asia. It tends to occur in West Africa and Central Africa and some parts of East Africa. Typically, for some reason, Portuguese, it's associated with the Portuguese speaking populations and the Portuguese diaspora. It's something to consider in someone who you saw who looked like they had HIV infection or AIDS, but was, any viral load testing was negative. So, Dr. Holland.
Thank you. So I will spend a few moments talking about when to initiate therapy in children, both those that have never been on therapy before and those that were started on regimens and you need to update them. So what I did was I used the WHO guidelines. They were recently revised, and I'll try to scatter any differences that happen here in the US as we move through them. So when to initiate ART, it's really the recommendation, taking into account what you have available where you're practicing, is that all people that are living with HIV should be initiated on appropriate therapy, regardless of clinical stage or CD4 count. Now we also know that ART availability is not necessarily the same in each country or location, and so you have to take that into account, as well as access to medication and whether or not the patient is willing to begin therapy. And so, one of the things that we've begun doing here in the US is what was termed rapid ART initiation. And that's really, once you've confirmed that they indeed have HIV infection, then, the day that you confirm that, or the day you evaluate them, then you should offer them treatment with ART. Now, there are a few exceptions, the most notable being TB, meningitis, cryptococcal meningitis, because of the risk of adverse reaction or immune reconstitution when you start them on therapy. And so if you diagnose those two entities, TB meningitis and cryptococcal meningitis, you'll want to wait at least 4 to 6 weeks before you begin their ART. So when you're thinking about, how to choose an initial regimen, you always want to go back to what are your goals. And so really what you're trying to do is reduce the amount of viremia to undetectable. And that will depend on which assay you have, which viral load assay you have. Ours here is less than 20, it could be less than 40 or less than 1,000. And what you're really, the goal of reducing your viral load is really to begin to have reconstitution of your immune status, or so that you don't lose any of your immune status. And so in general, you want to think about starting triple therapy, and that's going to include a dual NNRTI backbone, and you're usually going to pick an integrase inhibitor, a protease inhibitor, or an NNRTI. And so that's just looking at, you either have an INSTI-based or integrase inhibitor-based and NNRTI-based or a protease inhibitor-based therapy. And so this is just a schematic of where in the life cycle the different drugs act. So I will start off with the quote unquote least favorable regimen. The NNRTI-based regimens, they do have some advantages. There's going to be less dyslipidemia, less fat maldistribution that you will see compared to PIs. You will not be using a PI, which is often, especially as we think about, starting children and adolescents on therapy. PIs are usually one of the last things we go to because they have the highest barrier to resistance. You can have a lower pill burden if you use an NNRTI-based regimen. The disadvantage, the biggest for me at least, is they have the lowest barrier to resistance, meaning a single point mutation can confer resistance to that drug and or class. There is also cross-resistance between efavirenz and nevirapine, and that's especially problematic if nevirapine is used in part of your prevention to mother-to-child transmission of HIV. There is the risk of life-threatening rash. There's a lot of drug-drug interactions that you can have with NNRTIs, and so here I I rarely use them. I don't think I have any more patients that are remaining on an NNRTI-based regimen just because of all of these issues. So PI-based regimens, they're very efficacious. The child or patient can have, a lot of challenges with adherence prior to developing resistance. You do have the potential, especially with some of the earlier products, of having, complications, metabolic complications. There are lots of drug interactions. There is poor palatability of the liquid formulation, especially of lopinavir, ritonavir, that, where children actually refuse to take the medication. And so that in and of itself is problematic. The INSTI-based regimens, they have few drug interactions. They're very well tolerated. There's not that much data compared to adults and pediatrics. Another disadvantage is that, their availability may be limited. Dolutegravir and raltegravir do have pediatric formulations, but whether or not you have access to them really depends on your pharmacy and what your local guidelines say. So thinking about your first line ART regimens, dolutegravir is recommended for adults and adolescents, as well as infants and children, as long as they have approved dosing. And dolutegravir can begin to be used. It's approved for 4 weeks. If the child is at least 4 weeks old and 3 kilos, it can be approved, or it can be started. And that's with an RTI backbone, usually tenofovir with emtricitabine or lamivudine. I'll go to the next slide. So when you think about, your preferred regimen, if you don't have access to dolutegravir, efavirenz and efavirenz-based regimen will be your alternative first line. This is in places where you don't see a lot of efavirenz resistance. So if you have a lot of efavirenz resistance, you'll want to consider, and you don't have access to dolutegravir, you can consider access to either, starting a raltegravir, which is another INSTI, or a PI-based regimen. For children, dolutegravir again is now the recommended first line therapy. And the alternative is either Kaletra or lopinavir boosted with ritonavir. And lastly, efavirenz. A special note to neonates, especially in the first 2 weeks of life, if you're thinking of starting them on therapy, raltegravir-based regimen is recommended, followed by a nevirapine-based regimen. The special note is that if you're using lopinavir, ritonavir, you have to wait until they're at least 2 weeks of age, just because the formulation contains alcohol. So other issues that we run into in pediatrics, I think also in adults, but for some reason in pediatrics, adherence is a major component of what we do with each child at each visit. And so we monitor adherence, becoming very specific with them about how they take their medicine, how they remember to take it, where they store their medicine, and how many, especially asking how many times in that week or month have they missed their medication. As children age, they will have changes in their metabolism that's associated with both age and weight gain. And so if you have a younger child, until they reach about 10 to 12, you'll have to make sure that you're dosing them appropriately. You want to continue to monitor them for signs of toxicity, and this is, you'll be more concerned based on the different regimens you used with, NNRTI-based regimens and PI-based regimens having more potential for toxicity than your INSTI-based regimens. You'll have to make sure that your children are continued on their, not only the recommended childhood immunizations, but also the additional immunizations that they require because they're living with HIV. Long-term, children are more likely to have significant issues with virologic or treatment failure related to having been exposed to multiple different regimens, either used as part of prevention of mother-to-child transmission of HIV or because of their challenges with adherence. And so they're more likely to experience virologic failure. And then one of the things that is not recommended, but we sometimes very occasionally and rarely use is a treatment interruption. And usually we use this when we have adults, usually an adolescent that's refusing to take their medication or taking it so sporadically that they, really run the risk of resistance. And usually we have, we see significant resistance where their regimen, the available treatment regimens are already quite limited. And so in that situation, our preference is to stop their antiretroviral therapy and really address what is happening that's contributing to their challenges with adherence prior to restarting them on antiretroviral therapy again. When we do utilize this, we do monitor their CD4 counts extremely closely, usually a viral load and CD4 count every 3 months. And we usually work very closely with our psychologist in clinic. Going a little bit more into adherence, optimal adherence is taking more than 95% of your prescribed doses. As you take less than that, it's really, you have a sharp increase in your risk of development of ART resistance. Things that you can do to improve a child or adolescent's adherence is to decrease the pill burden. So we try to, as much as possible, place the child on a 1 pill once a day regimen. So it lowers their pill burden and it simplifies their dosing. We often will provide support and reinforcement in terms of congratulating them when they do a great job, and reinforce it, with the parent or the child, the importance of continuing to take their medication even though they feel well. We continue to provide education surrounding their infection at the appropriate cognitive level for them, using a disclosure story for those that are not disclosed to or don't know that they have HIV, and language that they understand. So you're taking this medication to stay healthy. We can tell by doing your labs that you're doing a fantastic job, and in doing that, the family develops trust with you as the provider. And we really look to the family to let us know when they are ready to disclose the diagnosis to the child. And so if ever a child asks, well, why am I taking my medication? I simply pause and wait, and let the family guide that conversation. This just is a schematic of why exactly adherence matters. So you can see that, you're more likely to have viral suppression the more adherent you are. So just in sum, the more treatment experienced the patient is, the less likely that subsequent regimens will be effective, and the more likely patients are to develop resistance. And so your best chance of success is with that very first regimen. And so we really try to impress upon the family the importance of taking their regimen, the importance of taking their medication. And often that's why we prefer a rapid initiation. In terms of monitoring, blood test monitoring, it really will depend on what you have available to you. In our clinic, we do viral loads every 3 months. The WHO recommends getting a viral load at 6 months, then again at 12 months and annually thereafter. If you don't have access to a viral load, CD4 count in your clinical monitoring should be used to diagnose treatment failure. But what we know is that is not superior to viral load monitoring. And so the goal at least is for everyone to have access to it, but we know that is a challenge that many places are still experiencing. If you do diagnose viral failure, virologic failure, and that's a viral load of greater than 1,000, really, what we do in peds is really intensive adherence counseling. If you have resistance testing available, then definitely try to use that. And then in my clinic, we usually do the CBC BMP or basic metabolic panel and the liver function test every 3 to 6 months. If a child's CD4 count is above 25%, then and they're adherent to their medication and they're virally suppressed, we usually go to annual monitoring of their CD4 count. Any questions?
I think we will ask all the questions at the end of this webinar. So thank you.
Okay, perfect.
So please stay with us.
Now I think Dr. Katrina Bird, she's here with us, and she is an internal medicine pediatric physician, adult. She's an adult infectious disease specialist and currently completing her pediatric infectious disease fellowship. She is the co-president of the Brown Minority House Staff Association for 2020 and 2021. And welcome Dr. Katrina Bird. And I think she's going to talk about success story of controlling pediatric HIV in Rhode Island. So welcome Dr. Katrina Bird.
Hi, I've been having some technical difficulties. Thank you for having me. So let's just go ahead and get started. Okay, can everyone see my screen? Okay, good. So we're gonna talk a little bit of general facts about children living with HIV in the US, and then we'll narrow it down to Rhode Island in particular. So as it was just stated, my name is Katrina Bird. I'm currently a pediatric infectious disease fellow. I do have my social media handles, my IG and Twitter. So if you want to follow me. All right, so let's just talk about a few things. So here in the US, and this information is focused on the US, perinatal transmission in general accounts for the majority of HIV infection in children who are less than 13 years old currently. However, our highest rates of HIV are in children who are 15 to 19. And this is primarily due to sexual interactions with someone who is HIV positive. That's the majority of transmission. We'll go through a little bit of detail. All right, so let's talk a little bit about perinatal HIV infection. So just in general, Dr. Holland mentioned a little bit about this. The patient population we treat, majority of children are perinatally infected with HIV. So just to back up and go through some of the basics. So for perinatal HIV transmission requires mom to be HIV positive. And so she can transmit the HIV infection to her baby during pregnancy. So in women, we really try one way to prevent moms from transmitting to their children is to quickly decrease the viral load as soon as possible if a mom is diagnosed with HIV in pregnancy. During labor and delivery, so this is actually the highest risk to the infant to get HIV because it's a lot of, just imagine child labor, it's a lot of trauma, a lot going on. So it's a high risk. And then breastfeeding, because we know HIV can be transmitted through breast milk. All right, so these are some just numbers in the US. Our most recent data comes from 2017, and this basically, in 2017, there were only 39 cases of new, like perinatally infected children with HIV that year. So here we're lucky in that our rates are relatively low. So this is a map of this is a map of all people living with perinatally acquired HIV by the end of 2018. So we're talking about over 12,000 people. So this is just a fraction of the people who are living with HIV in the entire United States. All right, so where we are currently is over 90% of the world's perinatal HIV transmission occurs in sub-Saharan Africa. So not necessarily in the United States currently. However, back in the day, as of 1998, perinatal transmission HIV represented all pediatric HIV infection in the United States, but that has changed. So just specifically looking at our numbers between 2002 and 2017, in 2002, we had 217 new cases of perinatal HIV infection in the perinatally acquired HIV infection in the US, as compared to a significant decrease in 2017 where we only had 39 cases. So the ways in which we prevent, I kind of went over a few things, but the best thing is really identifying HIV infection in moms. So here we screen when moms come in, hey doc, I'm pregnant, or I suspect I'm pregnant. HIV test is one of those tests that are done for mom. The other thing is we make sure mom is on treatment. So it's really important that we decrease that viral load as quickly as possible. So ARVs, so antiretrovirals, C-section, we offer C-section. So specifically, we offer C-section in women who have viral load over 1,000, very close to delivery. I want to say it's like about 35 weeks, or if the last viral load when they present to be, when they come in for delivery, if it's over 1,000, we offer C-section in order to decrease the risk of mother to child transmission. And here in the United States, we do recommend, our CDC, or Centers for Disease Control and Prevention, recommends moms not breastfeed. This is not the case in many parts of the world, because for many countries, breastfeeding is really essential for the infant's survival, for them to get good antibodies and protection against infection. So here, this is primarily a recommendation here in the US that's not necessarily worldwide. There, we do, if mom is really motivated to breastfeed, we can think about strategies to prevent that, but in general, we do not recommend it here. All right, so let's talk about other, HIV infection in kids. So when we're talking about newly diagnosed children living with HIV, how are they acquiring it? So when we are looking at males, and remember I told you the highest rates of HIV in children is at 15 to 19 years of age. So for men, for young men or young males, it's male-to-male sexual contact, or MSM. We also have a little bit of IV drug use, heterosexual contact. In regards to women, or females, it's primarily heterosexual contact. And we do have a little bit of IV drug use, but in both males and females, that's relatively rare. So just kind of breaking down a racial divide in regards to gay and bisexual men who have sex with men is primarily in our Black African American groups, have the highest rates, followed by our Hispanic group, and so forth and so on. All right, so now I kind of want to talk about, kind of expound upon Dr. Holland's talk in regards to the care of children living with HIV, specifically in Rhode Island. She gave you a lot of good information, so I just want to go through a little bit more detail. So regarding our pediatric HIV infection in Rhode Island, we currently care for about 34 children living with HIV. If you remember that map, unfortunately I don't have it but the map of the US, it was a lot of dark purples kind of in the southern parts of the state, dark purple representing where you have your higher rates. We're kind of like in the middle ground. So we currently care for about 34 children living with HIV. Most of the ages range between 8 and 22, and most of our children acquired HIV perinatally. And interesting, the majority of these children are either born outside of the US or their parent is originally born outside the US. So specifically, we do have a large patient population that either was born in sub-Saharan Africa or their parent is from sub-Saharan Africa. So, and the other thing, we do have a mix of families who have adopted children from other countries around the world, like Haiti, China, so forth and so on, who come into our clinic, and the diagnosis is known in that child prior to them coming in. Luckily in Rhode Island, we haven't had a perinatally infected child with HIV in at least 15 years. So we're very lucky. All right, so this is just an outside picture of our clinic. Unfortunately, I don't have any inside pictures. And so we just, given we have a relatively small patient population, we primarily just see our patients every Tuesday morning. So just a half-day clinic once a week. We do make some exceptions if kids have issues and they need to be seen other times, but we really do try to limit seeing our patients specifically on Tuesday mornings. All right, so let me just kind of go through a few details in regards to who takes care of our pediatric HIV population. So you've already met Dr. Holland. She's a pediatric HIV specialist. You've already seen her wonderful face and heard her voice, and you know she's very knowledgeable. So I won't perseverate on her. So next is Dr. Christopher Hulk. He is actually a clinical psychologist, and he's actually really essential to the team. So Dr. Holland kind of mentioned a little bit about what he does. So practically, he is at every clinic session and he meets with all of the children, usually prior to the medical team going in. And basically, he does so many good things. So in addition to kind of breaking down, issues with adherence, he also helps out with disclosure of HIV, because it's really tricky. The disclosure piece is so complicated as compared to adults. An adult, you're looking at the individual who has HIV and you are talking to them if they want to disclose to a significant other or a family member. However, for children, especially if they're perinatally infected, so children, developmentally aren't always ready to know, okay, what is HIV? So if you tell them too early and they don't understand the difference between what's public information and private information, they can blab out, oh, I have HIV to everyone and not really understand the consequences. So really talking to kids about that. The other thing is, because most of our kids are perinatally infected, if you tell the child they have HIV, you're essentially telling them that their mother has HIV too, because that's where, they acquired the infection. So it could be really, and some families aren't ready to do that, especially if they acquired HIV through sexual assault or some traumatic experience. So it could be really tricky. Additionally, he helps us transition children from pediatric care to adult care. And sometimes the kids really do have some mental health issues like depression, so forth and so on. So he really helps navigate these things in clinic and get children additional resources when needed. All right, so we usually have a pediatric infectious disease fellow. Currently, it is NG Jang, so that is her this year. And then we have case management. Now, case management is really integral in regards to the work, because a lot of things that our patients need happen outside the clinic. So here in the US, anyone who wants to be treated for HIV will have meds available to them. However, some families need help navigating the medical system. Some people need help with transportation to the clinic, to their appointments, so forth and so on. So our AIDS Care Ocean State provides so many, or ACOS provides so many resources. So this is one of my last slides, just kind of highlighting additionally some of the challenges we have in pediatric HIV care. All right, so Dr. Holland already talked about adherence to antiretroviral treatment. The one thing I want to add is sometimes it can be challenging, for example, the child to take their medication when their parent isn't taking their medication, or it can be a little bit challenging because sometimes we have situations where one child out of a group of children have HIV and the mom has HIV, but the rest of the household, including the husband and the other siblings, don't know they have HIV. And so it can be really, really, really tricky to make sure that their medication isn't discovered, but they're still taking their medication. We've already kind of talked about how disclosure of HIV to the child can be tricky. Really addressing the stress and trauma of the child and family, this really can be challenging. Sometimes, sometimes people come with stresses that we don't even realize that they're going through. So that's why our clinical psychologist is essential and really kind of get into the root of people's stressors, because these stressors will impact if they're taking their medication or the family is ready to disclose their HIV diagnosis to the child. Talking about sex, this is a good one because, our population is aging, they want to be sexually active. And so we really want to make sure that so the question is, what do you do in a child who's virally suppressed? You don't worry about them transmitting HIV to other people. You really want them to wear condoms or use protection, birth control, so that they are protected from other people. But, how do you handle a situation where someone's sexually active, but they're not virally suppressed? It can be really tricky. And these are some of the things we talk about. And lastly, just HIV prevention. I think a lot of pediatricians don't always feel comfortable giving PrEP. And so PrEP is designed to prevent HIV transmission. If a child is virally suppressed, their partner doesn't need PrEP, but it's a lot of, PrEP on, I want to talk about PrEP just quickly and then I'm done, on two different things. So here in the US, men or males who have sex with men are at high risk of HIV acquisition. That's where our rates are highest in regards to HIV. So and people who are engaged in have a number of sex partners. So these are the populations that you really want to make sure you're providing PrEP for. But a barrier is some pediatricians still don't feel comfortable even talking about sex, let alone PrEP. So this is an issue, and there's a lot of stigma when it comes to our pediatric HIV population. Just because you have HIV doesn't mean that your partner has to be on PrEP if you're virally suppressed. So it's a number of challenges we face, and I just think it makes it interesting, and that's why I love what I do. And I love taking care of people living with HIV. So thank you. This is me. This is my social media handles, and I'm going to stop sharing. Thank you so much for having me. I think myself, Dr. Larkin, Dr. Holland, we're all HIV docs, and we really, really enjoy the work. And we really do feel that we have an impactful and positive relationship with our patients. And we just love what we do. And we're more than happy to share our knowledge with you.
Thank you so much, Dr. Katrina. It was wonderful. And thank you all the speakers. And now I think we have a last speaker, Dr. Ijaz A. Khan. He's a pediatric and infectious disease specialist, Shifa International Hospital, Shifa Tamir-e-Millat University, Islamabad, Pakistan, and he chairs the IRB and Ethics Committee as well as the Infection Control Committee and Shifa International. So Dr. Khan, welcome. And Dr. Khan will talk about pediatric HIV care in Pakistan. Dr. Ijaz Khan.
Thank you, Bismillah ar-Rahman ar-Rahim. Thank you for allowing me to share my 2 cents on HIV care in Pakistan. Can you see my screen?
Yes, we can.
Okay.
We can see.
So I'm going to talk about a little bit maybe different, some aspects of Pakistani perspective on HIV. Years ago, when I came from US, I thought we did not have HIV in Pakistan, but many years ago, I remember that we saw a few patients, and it didn't make sense. And lo and behold, we started seeing these patients which were missed for many, many years. And of course, now we have a totally different picture. So things have evolved. I do not have any disclosure. So we know that Pakistan is a low HIV prevalence country, 0.1%. There are about 20,000 estimated new infections added to the pool of HIV. An epidemic is predominantly in key populations such as transgender, IDUs, and male and female sex workers. And more than 90% burden is in adult population. Pollution is not pollution population. But lo and behold, 2 years ago almost to the day, something happened in Sindh, Ratadero, is a town in Sindh, which has become a sore and tragic event for pediatric HIV care in Pakistan. We know that the speaker already pointed that in children, HIV infection is usually vertical transmission, but Ratadero epidemic had changed that perception for public health experts in Pakistan and maybe other countries as well. Because during that epidemic, 1,400 children were diagnosed with HIV positive, and most of the mothers were HIV negative. And it is believed that it was due to unsafe injection practices. So before March, this outbreak, children constitute about 4.1% of the total reported cases of HIV. But after this outbreak and as of March, this figure has almost tripled and the percentage has gone to 8.4%. If you talk about HIV care in general Pakistan, there are about 50 ART centers in Pakistan, but only 7 are dedicated to pediatric care, specifically to pediatric care. Rest are providing services both for adult and pediatric both. There are exclusive 16 PPT-CT centers in Pakistan, and most of them are working in OBGYN departments in these ARTs treatment centers. We have a national AIDS control program, which has been functioning for the last many years. It's a vertical program taking care of the HIV and AIDS patients. It has a large mandate. It has centers across Pakistan, many cities. It provides free of cost care in all PEDS ART centers, HIV medicines, diagnostic tests, including CD4 and viral load testing, and sometimes even HIV resistant testing. It has also been able to deliver ARVs by courier services to all HIV/AIDS patients who were unable to reach or access HIV center at their doorstep, especially during the last this strict lockdown. Of course, it also cares for some other aspects of pediatric HIV, such as food rationing packets to marginalized patients through courier services. Other medicines, such as for OIs, antibiotics, etc., provided to poor patients as well. It has coordination with EPR program for vaccination of all HIV children. Also, it has coordination with nutrition program for nutritional assessment of all HIV children. It also, the last speaker also talked about the important aspects of psychosocial support and counseling of parents on prevention, and of course, treatment and follow-up, especially in decreasing mother-to-child transmission. It, of course, does regular growth monitoring, ART centers. And of course, one of the other aspects is early infant diagnostic qualitative PCR, which is available for testing at 6 weeks of newborn, all were delivered by HIV positive mothers. So early treatment can be initiated. Nevirapine prophylaxis for all high-risk babies for 6 weeks till test HIV is negative. It also coordinates with PMTCT services with OBGYN department. And of course, behavior change messages, which is key component in understanding communities through this chronic infection through using different means, including toll-free helplines. It also has provision for hospital admission for any medical illnesses. And of course, it does coordinate with the hospital department for any other surgical procedure, etc. This Rotadero, or what we call which is near Larkana district, has also maybe infamously, now we have this Larkana toolkit, which is the new WHO regimen based on weight bands for different ages. And then, of course, we have new pediatric formulations for HIV treatment, which is depicted here. And of course, there is also some new pediatric formulations for HIV prophylaxis. And I think all these management guidelines have been alluded to in the by the previous speakers. So this is just a rough overline of first line ARV, which is based on weight bands and not age range. Of course, a child more than 30 kg, usually the adult formulation is recommended. And of course, then between different age weights, it has other drugs which are mentioned here. I'm not going to do in detail because I have to finish in 10 minutes. And of course, then the younger population, it has, as I talked about, newer medication which is available both for treatment and prophylaxis. I think everywhere there are some issues and challenges, and I think we are not different from it. And so we need a standalone pediatric care for HIV children in Pakistan. There are just a bunch of peds ID physicians in Pakistan. You can count them on your fingers, actually. And they've been in the forefront of dealing with making these guidelines, making available for training and outbreak investigation. Some of them have really done excellent job over the last few years, especially. Of course, the other issue is low PPCT coverage. And as I told you, there are very few centers in comparison to the adult ART centers. And I think we need a strong linkage between peds and adult ART centers. The transfer of PR-ship from national program to UNDP will be from 1st of July 2021. I think this is a new thing. Nutrition program, as I told you, there is some coordination, but needs a formal linkage, especially because children are very vulnerable, and nutrition is the at least in my point of view, that nutrition remains one of the key component in pediatric HIV care on a chronic basis. A lot of children and the parents live in the rural areas, distant areas, and accessing HIV services on a long-term basis becomes difficult for them. And of course, we need a lot of trained counselors for prevention and of course, prevention of HIV in children, taking care of especially mothers during their pregnancy. I've just listed a few points for the way forward for pediatric HIV care in Pakistan. So we need to have a one-stop solution where we have an integrated ART services, adults, peds, PCCT and PPTCT, because we know that a lot of times the parents are infected at the same time and they need to go to a same center to improve compliance. We need an integrated MIS between all these various components and centers. I think we need better government ownership to combat HIV/AIDS in Pakistan by dedicated PC1 as well. And then, of course, formal integration between nutrition program and HIV response for children. We need to continue our efforts for capacity building, as we know that HIV specialists, experts are very few, and we need to involve general physician, general pediatrician, and of course, formal HIV training using different modes. And of course, we know that we can use Penta trainings and APPNA platform for virtual trainings as well. And of course, expansion of PTCT and pediatric care services through integration with existing HIV treatment service. We need to increase to ensure that not every child is catered for, everyone is in the net for this in the services. And of course, extension of integrated ARTs, PPTC, and pediatric HIV care to district hospital, DHQ hospitals in high burden districts, which of course, we know some of them are already identified. Of course, one other way is universal testing of pregnant women in high burden countries, and then development and revision of guidelines, development of training curricula for PPTCT and pediatric care services, for focusing on the 4 pillars of PPTCT services. Capacity building already talked about, but includes doctors, nurses, counselors, and other staff. And steps for enhancing ownership and accountability of pediatric hospital management, and adaptation of standards for recording and reporting key indicators as well, so that you can take appropriate intervention and improve your services. And of course, we need integration of PPTCT IMS into the national HIV MIS. I think I will stop here. I just had a brief overview. And thank you very much.
Thank you so much, Dr. Ijaz Khan, and thank you all the speakers, Dr. Holland, Dr. Larkin, Dr. Bird. Excellent presentations by all 4 of you, and it was quite enlightening to know about the history of HIV in pediatrics, the treatment methodologies, the challenges we have learned. So thank you so much, each and every one of you. We have questions in the question answer section, and I know there are few questions have been answered already by Dr. Larkin, but we would like to have some live answers as well so that they can go on the recordings as well. So I'm going to ask few questions here. So Dr. Jerome, question is, I would like to know, apart from CD4 count, are there any preliminary and cost-effective tests that can be employed to screen the suspected maternal HIV cases, particularly in rural settings, primary healthcare settings of developing countries where minimal lab services are available?
Yes, so particularly in a lot of ARV rollouts in countries where resources are not as great, and where the focus has been particularly on mother-to-child transmission. We've done what's called pooled sera, which is you draw blood from 10 patients, you separate the sera, you put an aliquot, a standardized aliquot of sera from each patient into a single specimen pool, and you test that specimen pool after, adequately mixing it. If that test is negative for HIV antibody, then you can presume that all of the women who contributed to that pool are negative, and it sort of decreases your use of reagents and testing material by 90%. I'm not as familiar with that being used in viral load testing, which is one of our more important ways of assessing response to treatment. You could use a similar type of methodology. One of our colleagues, Rami Cantor, could probably answer that question a lot better than I can. I'm not sure if Sabina's or Katrina or Dr. Khan is aware of it. But theoretically, if you pooled sera from 10 patients who are HIV positive and then tried to do viral load testing and your viral load was undetectable, then you could presume that all of those patients have suppressed virus. And that is the biggest marker of response to effective antiretroviral therapy treatment. I'm just not positive that that's actually being used. There's also something called dried blood spot testing, where you can take a sample of blood and put it on, it's essentially filter paper. And then if there's a national area where their testing can be done, you can then transport them and you don't need to be worried about cold chain issues. And so you can have one central area in a given region where you are doing your testing, and therefore you don't have as many logistical or reagent issues. That's probably the single biggest barrier in resource poor areas is, making sure that your reagents are up to date, they're preserved, that the machines are working, all that stuff. I'm sure you guys are probably more familiar with that than I am.
Thank you, Dr. Larkin. Next question to Dr. Holland. What's the preferred regimen in thalassemia patients?
And so as I think Dr. Larkin answered, what I would just avoid is zidovudine, just because it has a potential to cause anemia, and we've seen it in our clinic. But otherwise, that's the only consideration that I can think of.
Thank you so much. Next question is, do we know if children who contracted HIV from needle sticks have a rapid or slow course as far as progression is concerned?
I don't know if Dr. Khan has an opinion about this, but there isn't a tremendous amount of data. I would think that if their infection is sort of later in childhood, when they're more immunologically competent, then their progression should mimic more like adults, but there isn't a huge amount of data. If the infection is very early in life, when there's still a lot of interaction between, or a lot of evolution of the immune system, then I think that the smaller children will be more at risk for progression more rapidly.
I think that's correct. I think even the viral load at the time of acquisition may make a difference, and probably also access to care and how compliant they are to the early treatment initiative, I think this Larcana outbreak will, I don't know the exact numbers over the years, 2 years, how many have been doing so far, but I think I will probably ask colleagues from AKU if they are around, they can answer that. Thank you.
All right, so next question is from Dr. Mayman. He's saying, thank you, Dr. Katrina, for a wonderful presentation. And I wonder if there's any non-clinical measure to prevent the emergence of pediatric HIV cases. I'm talking in situations like rural, less developed areas where HIV is associated with disgrace and stigma. Are there any societal advocacy measures to destigmatize this illness and bring awareness among prospective doctors? Thanks.
So thank you for the question. I think really controlling the HIV and infection in the population is going to ultimately prevent the transmission of mother to child HIV. I think it's tricky, right? So I think what's been helpful in kind of some areas where resources have been limited is really having community health workers, especially those people who are more knowledgeable to kind of, check on women who are pregnant and kind of ask some of those questions, kind of have a one-on-one kind of conversation with women in regards to, could they be at risk of HIV? And for maybe people living with HIV, kind of having some internal support. I think that's tricky when stigma is high, people may not be willing to reveal, that they have HIV. But I think in regards to really protecting children, screening would be ideal, but we're in a case where screening isn't available, really kind of increase just having more of an open conversation about HIV, and one-on-one kind of conversations work really well. But I think it's going to be an ongoing conversation, and it ultimately could be kind of challenging depending on the stigma. But really increasing the population's knowledge of HIV, condom use, access to condoms will ultimately decrease the chance of a mom spreading HIV to her infant.
Thank you, Dr. Bird. Next question is for Dr. Ijaz. Any suggestion of improving care and treatment of HIV treatment and prevention in Pakistan? Is there any plan to improve training more providers other than ID specialists?
I know that there's a national efforts and also provincial efforts in which many of the ID specialists, both for adult and pediatric, have been involved in training, especially after this Sindh outbreak. And I think it had improved a lot of this awareness, number one, and also improving access to care and also diagnostics available. And of course, this probably will have a ripple effects across Pakistan. And I believe that this is the way forward, that we need more centers, more experts. Of course, diagnostic tests are available, but becomes a problem if you expand your services depending on your resources and your funding. So as I talked about, if you expand to DHQ, then you have to talking a big step. But I think key centers across major cities and towns is the way forward to begin with.
Thank you, Dr. Ijaz. Next question is, as in adults now we have treatment for all irrespective of CD4 count. Is it the same in HIV in children? CD4 has same importance?
Yes, important. Of course, the CD4 remains one of the key indicators, especially for monitoring purpose, and of course, your response to therapy and picking up possible resistance, because this is much cheaper than in the viral load, especially in our setup. So CD4 remains an important component for at least monitoring treatment and picking up possible resistance.
Thank you. And there's another question is, GPs in Pakistan, can they be trained to treat HIV?
Of course, if they have interest, especially if they have dedicated time, if they have dedicated time and their resources, especially, it can be done. Because remember that the expert is available for treating the specific key major aspects of HIV, including like complications, including unusual manifestations, and then you need expert to be involved. GPs can be involved in the long-term care, especially for monitoring, for nutrition, immunization, general care, counseling. and GPs remain an important backbone of our society. I think we need to engage them. If not GPs, at least a pediatrician, because we have thousands and thousands of pediatricians who know how to take care of pediatric aspects, whether it's general care or specific infectious disease like HIV.
Yeah, I agree, Dr. Ijaz. I think it's important to at least give some training to our GPs, because they're the backbone of any society or medical society, and they can help in screening and then counseling and long-term care of HIV patients. So thank you so much. I don't see any other questions. Dr. Fiza, do you see any questions?
Yes, sure. Actually, there are a few questions about what is the WHO recommended EID test for newborn whose mother is not virally suppressed. So, Dr. Ijaz, I think you mentioned EID test in your presentation. So can you please answer this?
Can you repeat the question? What is it?
Question is, what is WHO recommended EID test for newborn whose mother is not virally suppressed?
I think it can be used, especially if you do not, if you have the availability, because it is one of the key diagnostic tests that can be available, that is available and can be used. But I think just doing PCR also 2 weeks or down after the delivery can be done if EID is not possible.
And another question from same participant, that is CD4 count is as important in children as it was supposed to be in adults?
I think I already answered that. Fiza, I already answered that. Okay. Yes, it remains to be important for both monitoring and, yeah.
But here in USA, CD4 test is not very in practice now. Dr. Larkin, can you answer this question?
Yes, only insofar as once a patient, I would agree with Dr. Ijaz that it is very important in terms of monitoring clinically what's going on, or even more specifically, what the patient might be at risk of. So if the CD4 count is less than 200 in an adult or older child, or less than 25% in a younger child, we worry much more about the development of opportunistic infections, and certain ones we prophylax against. The reason why CD4 count has fallen, not out of favor, but more out of use, I should say, in the United States, is when you have someone who has had durable viral suppression and immunologic function restored. So if they started out with a CD4 count of, say, 150, but then over the course of antiretroviral therapy, they went up to 500, as long as their viral load remains suppressed, then we can presume with good evidence in the medical literature backing us up that they will stay at that 500 level, that they are no longer at risk. So it's, as a practical matter, it's easier to just follow viral loads. And if you know that their CD4 count was high to begin with, or achieved a certain level, as long as their viral load remains suppressed, then their CD4 count shouldn't be dropping. So it's really a cost-saving measure more than anything else. Having said that, most of us will still check a CD4 count every year or so, but some will not. And the only other use to it is that, again, in someone who is virologically suppressed, but and immunologically reconstituted, it's powerful positive feedback to the patient to remain in care. So if you know that, hey, my CD4 count is now normal, and we do have patients who achieve normal CD4 count levels, I know that I'm healthy. And that's, very, I think, liberating and reassuring to the patient. But it is an expensive test.
Thank you so much, Dr. Larkin. I see one question in the chat box. It's regarding C-section during pregnancy. The question is, ACOG recommends C-section at 38 weeks of pregnancy. So when should it be done? 35 or 38 weeks?
So the primary benefit for C-section is it does have a marginal improvement in decreasing transmission for women whose viral load is greater than 1,000. Under 1,000, then we're comfortable letting them deliver vaginally. That has to be taken in. So the timing in terms of gestation isn't really taken into account. What is taken into account is whether or not the membranes have ruptured. If they've had spontaneous rupture of membranes, then there's no additional benefit to doing a C-section, even in a woman who's got a viral load over 1,000. And that has to also be taken into account in terms of what the risk of C-section might be in any given setting, because C-section itself is a perinatal risk factor. So if a woman was otherwise going to be able to deliver healthy, in a healthy fashion vaginally, and resources to perform C-section were not secure, then I'm not sure I would proceed with that. It's only a couple % improvement in the overall statistics. Hopefully that helped. It's kind of a complicated answer.
No, thank you so much. I think it was quite helpful. And there's another question coming up. If undetectable, can women breastfeed?
Sabina, you want to do that one?
Sure. We get asked this a few times a year. I think, in terms of the data looking at, undetectable is untransmittable, that was done in a certain population looking more at sexual transmission. And so while, the probability of transmission, especially if they're undetectable throughout pregnancy and before and have immune reconstitution, I think the probability of transmission from mother to infant is low. It's not zero. And so I think in the conversations that we have with the mothers, it's really a shared decision-making model, and that we, if the mother is suppressed, we will start the baby on ART and then monitor the mother's viral load, recognizing that that she could have a blip or a detectable viral load. I think it's low. I think the benefits of breastfeeding may outweigh the risk of that low transmission, but there's no data.
I think the other thing that has to be taken into account is what is the safety of substitution feeding?
Right.
And that, again, in some places, there's virtually no risk to using formula versus breast milk. Whereas in other situations, breastfeeding is going to be far safer than substitution feeding, particularly if it's reconstituted formula with whatever available water supply is there.
The other thing that I counsel moms on is not to stop and start breastfeeding. So it's exclusive breastfeeding until they choose to wean the child.
Thanks a lot. And I think, Dr. Fiza, what did you think? We have answered most of the questions now. So
I think so. If I'm not sure if this question was answered. This is from Dr. Umair Malik. He is asking, can we do quantitative PCR for newborn if EID qualitative PCR and AT is not available? So Dr. Ijaz, can you please?
Yeah, I think we can do. I think I partly answered that a little while ago. So we can do that, yes, because if it's PCR can be done, yeah, as an alternative.
Okay. So I don't see any other question. So let's ask from audiences. I think if there's any question, please raise hand. Otherwise, we can conclude our session for today. I think go ahead and we should conclude this session. So Fiza.
Yeah, so I think it was very, very good session today, and we learned quite a bit about pediatric HIVs, presentations and treatment, and learned the challenges, how to deal with them, especially in Pakistan. I know we have many challenges we are facing, but this is a good start that has been taken by APPNA-MERIT and also from Pakistan. Great collaborations. At least we have started with awareness sessions now. There's lots of work that needs to be done, but there's always first step, and there's always a beginning, and we are all here. And I'm really thankful to all the speakers who took their time, especially on Sunday morning, to be here and give their presentations. It's a great team, and we would like to work with you in future as well. And thank you, Dr. Fiza Gilani, for all your initiatives and your leadership. We are proud of you. And thank you, everyone, whoever joined us in Pakistan on Sunday evening, especially. I know it's hard. Monday is a working day. Everybody has to go back to work. So I wish all of you all the best. Stay in touch. We will be having our monthly webinars. We will come up with another exciting topic related to HIV next month, and we will update all of you. And I wish you all the best. Have a great week and great month ahead. And thank you all.
Thank you for having us.
Thank you for having us.
Dr. Fiza.
Bye, everyone. Take care.
Thank you.